Hello, good evening. How are you today? Welcome to another episode of Become a Better Man. I believe your day has been wonderful because this weather has definitely been amazingly hot. But I'm not complaining. We've been waiting for summer for a long time. Thank God it's here and hope it will last long. My name is Tunde Disu and you are welcome, very, very welcome to another gathering of Become a Better Man. And once again, I have with me on this program, like I promised during the week, I have my dad with me, Dr. Daniel Imoideme, who has been graciously feeding us with wisdom, with knowledge, with understanding, especially in the area of reproductive medicine. For those of you that have been part of this program in the last 5-6 weeks, you will have seen and you will agree with me how much ground we have actually covered in the course of looking at this topic. But for the sake of those who are probably joining us for the first time this week, well, let me first of all extend a warm welcome to you. You are in good place. You are in fact the best place you could be at this time, because what we're about to go into today is another facet, another angle, another area of the reproductive medicine, especially talking about infertility. But not just infertility in this week. We're looking at the treatment. Because for those who were with us from the beginning, we've looked at what's infertility, what are the causes, the female reproductive lifespan. We've looked at investigating the infertile couple. We've looked at the pre-treatment procedures and everything. So this week we are actually looking at treatment of infertility. What are your options? What are the choices that are available to you? Because sometimes it is not because we don't want to be treated, but ignorance is one of the biggest things that is robbing people of their answers and their breakthroughs. But at the end of the day, like Dad will tell us as we go along, it is your body, it is your life, and it is your decision ultimately. But unless you have a knowledge of what are the options available to me, what are my choices, you are left with whatever is on the table. So today we're going to be looking at the choices and the options that are available to you when it comes to treating infertility. I know you've been waiting for this, and I can see a lot of you already joining. Please let me encourage you. As you join, let's go and share the program. Let's call our friends, call those people we have already spoken to, and remind them that the program has started. I am going to keep quiet very soon, and I'm going to release the camera to Dad to really take his time and talk us through this topic today, talking about treatment of infertility. Dad, once again, on behalf of everybody, we want to appreciate you, we want to thank you for taking this time out to be with us, to help us, to teach us, to train us, to enlighten us, to give us options and choices, to open our eyes to see some of the things that perhaps we will probably never have known. So, sir, we appreciate you. Thank you once again for joining us. Ladies and gentlemen, I'm going to keep quiet now, and I'm going to turn the camera over to Dad. Up to you, sir. Thank you, sir.
Good evening, everybody. And I'm sorry we had to skip last week because the educator, I will say, needed to be educated. I had to attend a program which was very dear to my heart, and it came very suddenly, and that's why we missed last week. But I hope that you still remember all the stuff we've talked about in the last, 4 or 5 sessions. And today we are beginning to look at putting together and tying together all the facts that we have gathered in the last 4 or 5 talks that we've had, and beginning to move forward now and say, look, what are the options for me? Today's talk will be a bit non-specific, because if I were talking to an individual couple, I know their problem and I can tell them exactly what they themselves require to have done. But because we are going to be looking at more like a panoramic view of the various aspects that can happen, various things that can happen. No two couples are the same when it comes to infertility. Somebody might have problem with our tubes, another with ovulation, another with the male, and also all sorts of combinations of those. So we will be looking at what are the possible options when I've gone through the diagnosis, the investigation diagnosis, and gone through the pre-treatment preparations. What then are the options for me? So we'll be looking at more like a generalized aspect of this area of the talk, and I've broken this aspect into 2 parts because I want us to be able to understand a lot more. The first part, which is today, will deal with the much simpler aspect of treating infertility, because infertility, like we already said during our discussion, can be just a very minimal, a minimal problem which can be easily resolved just by simple advice or so, or can be a very complex situation that needs to be dealt with some highly technical procedures and practices. So today we're going to be looking at what are the potentials or the potential treatment of, again, hypothetical situations, and then move on from there stage by stage, see what those treatment options are, see what they are likely to be able to produce, see what we should be expecting from them, because infertility treatment is not a guaranteed treatment. I always say to my patient, if I go to a surgeon, he removes my appendix, I'm never going to go to another surgeon to have my appendix removed again, because it's gone. But infertility is different. I want to have a baby. You have a treatment, there's no guarantee that it's going to work. Perhaps at the very best of situation, anywhere between 25% and 40% chance of it working. That's the very best you can get out of it. That means you are looking at a 60 to 75% chance of not getting pregnant and not having a baby, when you start a treatment. Therefore, it's a treatment that's full of pitfalls, full of frustrations, but you need to brave yourself and say, look, here I am, this is what I have to do. I have to put in the best I can in order to be able to get out what hopefully I should be able to take home a baby. That is the end point of an infertility treatment. It's not whether you get operated upon, it's not whether some sophisticated treatment has been carried out. No, it is, have I got a baby in my arms to take home? That is the end point, and that is the only positive end point that one has to look for. So let us begin by looking at the situations from the very simplest of situations. We did say that up to 30% of patients who come to infertility clinic, couples who come to infertility clinic, have nothing that can be found wrong with them, yet they're not getting pregnant. Now, is the issue something to do with the understanding of the fertile period? Is it to do with the cycle of the lady? They do not quite understand how the cycle works, and that only 2 to 3 days maximum in a month is considered the fertile period during the cycle. The rest of the month is a waste of time when it comes to getting pregnant. Okay? So, the first thing will be, assuming that we have a couple sitting in, I have a couple sitting in front of me, and I can't find any reason for them not getting pregnant. Maybe they've tried for about 6 months and nothing is happening, and they just think, look, we got to get moving. And I will say to them, okay, look, these are the results. What we will want to be doing is to educate the couple on what the cycle, the menstrual cycle is like, because that is very crucial. Understanding the menstrual cycle, and at what phase of the menstrual cycle, what days of the menstrual cycle is likely to be the fertile period for a particular lady, because no two ladies are the same. A lady who has a 26-day cycle, like I said the last time, will have her fertile period between the 12th day and the 13th day of the cycle, whereas one who has a 28-day cycle will be slightly later, maybe 2 days later. That's the way it works. And if a lady has a 42-day cycle, then of course her fertile time will be somewhere much later, in the 21st, 23rd, or 26th day of the cycle, depending on the length of the cycle. So an education or understanding of the cycle is one of the first things that we need to let the couple know. Once they understand, then they know that that is when intercourse should be concentrated upon. It doesn't mean that they shouldn't be their normal husband and wife, but again, I have seen situations where it apparently degenerated to a situation where the wife only says, look, we want to have a baby, it's only on the 12, 13, 14, that's it. It creates psychological problems, it creates difficulties between couples. But a clear understanding is just a working knowledge for the couple to be able to say, yes, we understand how our body works, and therefore we are going to maximize using this mechanism. There are things that you can do to assist yourself in understanding when the ovulation is likely to occur. One, for example, is the urine testing. There's a kit which we call an LH kit, L and H. L for Lagos and H for house. LH kit is available in most chemists. It helps you if you do it from somewhere around the 9th day of the cycle, until you get, usually it's usually a blue strip that you see. You wear on the strip every morning, and then you look at the strip, and when it turns blue, it means you have started releasing the hormone that matures the egg. And therefore, 24 to 36 hours later, you are likely to be ovulating. So that's a very nice way of doing it. If, for example, you don't want to get the doctors involved in it, you want to be very private about the whole affair, fine. You go in, buy this kit. You've been told there's nothing wrong with you. Okay, we buy the kit. Time attempts at the correct time.
So that
yeah.
This LH kit is different from the one you use to test if you are pregnant or not.
It's the same company that manufactures them. It's different, but it's on the same principle. Okay. It's exactly the same principle. In fact, in 1982, 83, 84, I was involved in developing this particular kit. The very first time that we were trying to develop a kit, because it was so difficult to get women to be able to help themselves without having to come into hospital to do blood tests that require them waiting till the next day to get a result. So we were developing this, and eventually a company took it up and developed it, and now it's available. You go to Boots or any of the big pharmaceutical or dispensaries or so on, you will get it. Just say ovulation kit. Okay, and you'll be able to get that. From day 9 of your cycle, you do testing every day. You know, you just weigh on the strip. It's like a urine strip for testing for sugar in the urine. You know, and you weigh on it, and then you can see whether the blue lines have occurred, which means that the hormone has started being produced. And therefore, you know that within the next 24, 36 hours, ovulation should be happening. We can augment this particular kit with ultrasound scans. That, in fact, will help us to sharpen and define exactly when things are likely to happen. One, the ultrasound scan will help you to monitor the egg. We call it the follicle. When the follicle size reaches somewhere around 18, in fact, we usually tell you to start testing from around 15. You're testing every day. Then you know that you are getting nearer and nearer and nearer. Usually most follicles will ovulate around between 18 and 25 millimeters. That is 1.8 to 2.5 centimeters. That is the range generally. Some may get bigger, some may ovulate a little earlier, but generally that is the range when ovulation actually happens. So by combining both, you are actually likely to get a more accurate sort of timing of when ovulation is likely to happen. Now, the man doesn't seem to be doing much about this. He's just waiting and watching. But we always say it is better that the man abstain for at least 3 to 5 days. The whole idea of it is that sperm concentration, you want the optimal quality of sperm in terms of number, in terms of movement, in terms of those that are living, not dead sperms. Because the longer the abstinence, the higher the number of dead sperms. You know, and if the frequency of the abstinence is too little, then the number of sperms will be fewer. And the whole idea, you want sperms, adequate number of sperms to arrive at the fallopian tube, where the egg and sperm will meet in the far end of the fallopian tube. So if there are enough sperms, then you are likely to have enough travel all the way through the womb, through the fallopian tube, to the other end of the fallopian tube, nearer the ovary, where the egg and sperm will interact. So basically, simple advice, understanding the menstrual cycle and knowing that ovulation does occur within a certain frame of time depending on your menstrual cycle, the length of your cycle, 26 days, 28 days, 30 days, and all that. If you don't want to even do anything at all, the general impression will be, if your cycles are regular, count backwards from the day your first day of the period, count backwards 14 days. 14 days earlier, before the day you started your period, was the day you actually ovulated, most likely in about 70% of women. So 14 days from counting backwards, not going forward, counting backwards. So if you look at that for 3 consecutive months, you can then see what the range of ovulation days will be for you as an individual and how you can concentrate on that. Some women do not, in fact, let their husbands know. I mean, you come to the clinic, they don't want their husbands, and they want it to be their own little secret because they don't want, intercourse to become a mechanical event. Especially with the men, they can psychologically get, put off. So this is one step in the process. Nothing is wrong at all. This is unexplained infertility. Periods are fine. Sperms are okay. We don't know why this is happening. Then we want to maximize the chances that the egg and sperm will meet. So this is the basis for understanding when ovulation is likely to happen. So we can then go on to, oh, that stuff is, okay. Okay, the next stage will be, for example, we want to interfere minimally, with, the whole process of timing intercourse, and, we want to also improve the chance that things will happen. In order to do that, we can increase the number of eggs. For example, let's look at a lady who has very irregular periods. So, I'm not sure how many of you would have heard the diagnosis polycystic ovary. These are women who have lots of eggs in their ovary, but they are not ovulating. They may ovulate once in 6 weeks, once in 6 months, once in 3 months. It varies so widely. Some of them may not ovulate, menstruate more than once a year. But they do have eggs, but these eggs are not maturing, in which case you want to stimulate the ovary to produce a mature egg. The other reason why you want to stimulate the ovary to produce a mature egg would be maybe the sperms are too few. We did say the last time that about 20 million upwards per mil is what the WHO, the World Health Organization, says it should be. But supposing this guy has anything between 10 and 15 million, it's not too bad, but still not meeting the criteria. So what can you do to assist if this couple do not want to go to, either they don't have the money for it, or they don't want to go into a complex treatment like test tube baby in vitro fertilization? You can stimulate the ovary. The idea being that you want to increase the number of eggs in a situation where there is some compromise on the male side. But where the male side is normal and it is purely a situation where the girl is not ovulating regularly, then the aim of stimulation of the ovary will be to get one egg. I will come to that in a minute, why we are looking for only one egg. Now, in the case where the man has a problem, we think it's not a severe problem, it's just a moderate problem, then you want to increase the number of eggs. And hopefully you think, look, even if the sperms are few, if there are 2 or 3 eggs, perhaps the sperm might get one of the eggs fertilized. But I will warn you that it is possible that all 2 or 3 eggs, or whatever number there are, can get fertilized and end up in a multiple pregnancy, which is something that, again, we do not quite, want to happen because of the complexity, pregnancy miscarriages that can happen with multiple pregnancy. Now, if it is only ovulation problem, then you only want one egg to grow, and you use the ultrasound to monitor the ovary to see how it is growing, the follicle is growing, and when it reaches a size of anything between 18 and 20 millimeters, we usually do what we call induction of ovulation itself. That is maturing the egg by giving either an injection to mature that egg, depending on how we have stimulated the ovary. You will ask me, how do you stimulate the ovary? Yeah, I'm sure those who have been to fertility clinic or have had relatives going to fertility clinic would have heard about tablets of Clomid, being used, or tamoxifen. But basically, the most important sort of method of stimulating the ovary is an injectable injection, which is FSH injection, because it is the same hormone that the body produces to induce growth of eggs in the ovary. By giving you small doses of that, you can actually grow one egg. But it's a tricky business. There's no guarantee that you will grow only one egg. You may end up growing 10 eggs, and in which case we will tell you we are not going there. We will cancel because it's too risky, the chance of a multiple pregnancy. I had an episode in 1988 where I ended up with a lady, even though I advised them that it is not advisable to have intercourse, they went ahead all the same. And she ended up with 5 boys. I have a picture of them, those boys here. They all survived. I delivered them at 32 weeks. They all survived perfectly well, and they're all big men now, grown up, sort of 1988. That's why 26 or 28 years or so. So that can happen. But can you imagine 5 babies in one house at the same time? For those of you who have had a baby, you know what it is, coping with a baby, especially in the first few months after delivery, coping with one, and to cope with 5. That's a complex situation. The economic implication as well is something that is major. Apart from the complications in pregnancy that can happen, blood pressure problems, this lady was in hospital for 12 weeks before she delivered, from 20 weeks on. And by 32 weeks, she told me, I just want them out. I don't want them anymore. Just take them out. And I had to do a cesarean section, and thank God they all survived and they are fine. Now, that is something we don't want at all, because we do not want to burden the couple that only wanted one baby with such a burden that they will find themselves economically, socially, and name it, overwhelmed. Okay? So that's the problem with stimulating the ovary. When you stimulate the ovary, you never really know what you're going to get. The first time you try, you may then reassess what you do subsequently. If this time there were too many, you drop the dose of medication. It's a trial and error sort of situation, because you can never predict how a woman who has polycystic ovary in particular will respond. A lady who has regular menstrual cycle, but we are doing it for the sake of the husband's sperm that is a bit, slightly abnormal, that's not a major risk. We tend to be able to get 2, no more than 3 follicles, we call them, because then we know that we will reduce the chance of multiple pregnancy. So it's a very, very tricky situation trying to, stimulate the ovary and try to get an adequate stimulus and get things done. Now, that is where we've been looking at where we are looking at intercourse. This couple did not want any interference. They didn't want any third-party involvement in it, which is the third party being the doctor or the nurse in the hospital, carrying out a procedure, for the sake of either putting sperms in or into the womb or whatever. But there is that option then comes in. If you have tried all these other options that I have outlined now, education, knowing your menstrual cycle, knowing the ovulation time, stimulation, whether 1 or 2 or 3 follicles, because you are not ovulating regularly, or because the man's sperms are a bit inadequate. You've tried that for 3, 4, 5 months. You're probably likely to come back to your doctor to say, look, can we try something different? And that is the thing, that we usually will look at between 3 to 6 months of trying this various treatment. If you still haven't achieved a pregnancy, then we begin to ask ourselves, 1, the tubes, even though they are open, are they functional? We mentioned that in the last discussion, that the tubes may be open, but they may not be functioning adequately. 2, the sperms, we have normal count of sperm, movement is fine, everything looks fine. But are these sperms able to fertilize the egg? We don't know. Are they actually reaching the site of fertilization? We don't know. Are they dying prematurely in the womb cavity or in the fallopian tube before they get to fertilize the egg? We don't know. So really, when you have done all of this, done all the advising, the stimulation, and all the rest of it, and you haven't got a result, you have to step back and say, well, maybe we should move forward. It's a step-by-step situation, starting from just simple advice, understanding the cycle, stimulating the ovaries, and trying to get eggs to grow and ovulation. Now, what next should we be looking at? The other option will be, well, artificial insemination. I'm sure that those who have been to clinics before would have heard somebody mention something about artificial insemination. It sounds weird. Artificial? Where are we going to get what to inseminate? What is it? And that can be a bit intimidating for both husband and wife. Why? The first questions I will usually get is, how are we sure that it is going to be my husband's sperms that you'll be using to inseminate? How are you sure that there'll be no error or mixing or mistake in the lab? These are matters of confidence. Having confidence in your doctor and the lab that is involved in treating you. There's no other way to it. When we are doing artificial insemination, it can be in a natural cycle. In a patient who has normal cycles, she's ovulating, we know that she ovulates normally, we've done tests and we know she's ovulating, we've done her LH testing, we've done her ultrasound scan, we know she ovulates, but we're just wondering, why is she not getting pregnant? Are the sperms not getting there? Then we may say, look, why don't we try a number of artificial insemination treatment cycles? What that means is we will either monitor the natural cycle, if the lady is ovulating normally, in which case there's no risk of multiple pregnancy. When we then do all the LH testing and the ultrasound scan and we pinpoint when ovulation is going to happen, we will bring her in, get the husband to submit a semen sample. We prepare the sample. I mean, if I use the language of what we say we wash the sperms. It may sound a bit, how do you wash them? They are such tiny little things, but these are technical bits. We actually wash the sperm, wash away all the dead ones, capture the moving ones, and those, and take away all the debris that may be there, and get pure sperm sample in a suspension of what we call a culture medium. Then, just like in a normal routine examination of a female, a gynecological examination, we expose the neck of the womb and load the sperm into a catheter, and then pass that through the neck of the womb into the cavity of the womb. That's why you will hear not just artificial insemination, most fertility clinic will tell you intrauterine insemination. So you are not just inseminating. In the 50s and 60s, 70s, it used to just be putting the sperm in the upper part of the vagina. No, it's no longer so. It's now you wash the sperms and you actually inject, you help them more than half the way up. So you inject them into the cavity of the womb and hope that from then on you will get an adequate number of them arriving in the fallopian tube. Again, there's no guarantee that this is going to happen, that the pregnancy will happen. But one of the other complications that can happen, which again can also happen in the earlier methods, is ectopic pregnancy. Supposing The reason why pregnancy hasn't been occurring is because the tube has some problem internally. The little hair-like projections that move the egg through the fallopian tube have been distorted either because of an infection that took place before, either from a previous delivery or whatever it was. Now, that egg that has been fertilized may continue to move and get stuck at some point and end up becoming an ectopic pregnancy. All right? But by doing artificial insemination, you actually have, increase the chance that the egg and sperm will meet. All right? Now, you can do the artificial insemination in a natural cycle. You can do it in a stimulated cycle. And when you are doing it, we usually limit ourselves to no more than 3 follicles of maximum 15 millimeters or more. If we have more than 3 follicles of 15 millimeters in diameter or more, we will advise you to stop, because the risk of multiple pregnancy is too high. Pregnancy may not happen at all, but if it did happen, then the risk may be high. So, artificial insemination you carry out, it takes about 5 minutes to complete, and you lie there for about another 10 minutes if you like, and then get up. It doesn't really matter whether you get up straight away, because the sperms are right up in the womb. They're not likely to drop, but for psychological reasons, most women would like to lie there for a few minutes and then get up and go home. You will hear different versions as to whether or not 1 or 2 inseminations, which is better, 1 or 2 inseminations. The important thing is, if you have monitored the cycle and you've monitored the ovulation and you've timed your ovulation properly using your ultrasound, using your ovulation kit, then it's unlikely that doing your insemination the second day will make a difference to the treatment. In fact, I have looked at that, also years ago, looking at doing 2 inseminations, and then compared to doing 1 insemination. There was no difference in the pregnancy rate. And we did some of that again here in the UK, and there was no difference in the pregnancy rate. But some women will say, look, psychologically, I want to be sure that, I've done everything. I want to do it, on 2 consecutive days. Fine. That's a different story. It's a choice of the lady. But generally, 1 day of insemination, a day that has been carefully monitored as the day of ovulation, you can actually, after the scan, after the artificial insemination, have another scan the next day instead of doing another insemination, to find out whether your egg has actually ovulated, because by ultrasound you can see whether or not that egg has ruptured, that follicle has ruptured and released the egg in it. So you know that the lady has actually ovulated. So this is one of the things that can happen. So you can either advise the lady if everything is fine. You can assist by way of monitoring the cycle through the LH kit, through the ultrasound scan. You can assist by stimulating the ovary for the reason, 1, that she's not ovulating regularly, particularly polycystic ovaries, a very common condition amongst women of the African origin as well as Middle Eastern origin. It's very common. So you will find that your doctor may recommend ovarian stimulation, but the problem there is what we call ovarian hyperstimulation. These women are very, very prone to having excessive response to even a small dose of medication. Where you expected to have 1 or 2 eggs growing, you have 20 or more. Therefore, you cancel. And the drugs are not cheap. the expectations that you were already embarking on a treatment and you were looking forward to completing the treatment, the psychological trauma of it, the time wasted coming back and forth to hospital to be monitored, these are all wasted because we think, look, the risk is too great, sorry, we are going to cancel your cycle. So there are a lot of pitfalls, and I can't overemphasize it. Anybody who's embarking on a fertility treatment should know that when you come out at the other end with a baby, remember that maybe about 50 to 60% of other women or couples who have walked into that clinic have walked out without a baby after all the treatment. So it's something that you need to psychologically prepare yourself for. I don't know that you can actually do it, but at least being aware makes it easier for the team that you are looking after. Because some people may come and say, oh, we spent so much money in this clinic and we haven't got a baby. A doctor, a nurse does not produce a baby. They only help you to achieve a condition where you have an increased chance of a pregnancy and hopefully a baby. And again, fertility treatment does not say that miscarriages won't happen. Miscarriages can still happen, even with fertility treatment. But once a pregnancy happens, it carries on as any other pregnancy. It got the same risk as any other pregnancy. The fact that you had stimulation of the ovary has nothing to do with whether the baby is normal or abnormal. It doesn't affect the baby. It doesn't affect how the pregnancy goes or whether the weight of the baby will be fine and whether the baby will be neurologically normal or not. No. Once you've gone through the process and gotten pregnant, it is exactly the same sort of risks that you'll be taking as any other pregnant woman will be taking with her baby. So this is, at the moment, this is what I would like us to look at, and I like you to reflect on all of this. Where am I if I have a problem with fertility? Where am I? Or you have somebody who has a problem with fertility. Most people don't like to talk about it, unfortunately, which, is a very private and a very personal situation. But where you are able to talk to somebody who has this problem, then you can help them decipher the truth from the myth, and say, look, these are what I heard can happen. This is what you should be asking. You go to your doctor. What I expect you'll be able to do after all this series of talk we are having is to be able to be knowledgeable enough to ask your doctor questions. That is why I said 1 or 2 sessions ago, I need you to ask me questions.
Yeah.
Because that is the way I run my clinic. You come to my clinic, we talk, I get a history, examine you and all the rest of it. Then I listen to everything you got to tell me. I have to tell you based on what. Then I ask you, what have you not understood? What is it that is there at the back of your mind that hasn't been answered? Because, as I always say, it is a journey between you and your doctor. You don't know where you are going and how you are going to end up. The best you can do is to make sure that you understand where the doctor is taking you, and it is what you want, because the choice is actually yours. It's not the doctor's. If you say, I don't want to have my ovary stimulated because I've heard some story about cancer after ovarian stimulation. Okay, yes, you have a right. That is something that people have talked about, cancer after ovarian stimulation. But all studies so far that we know, this has been going on since the 60s. studies that we know have not proven out conclusively that if a lady doesn't have a predisposing situation to cancer of the ovary, that ovarian stimulation by itself will induce cancer in the long term. There is no proven study at the moment that says that. Otherwise, things will be reviewed. Okay? So I expect that you'll be able to ask your doctor more questions as you learn, as you hear some of the things that I've said. The areas that I've touched today is so broad, I cannot, if I sit with a particular couple, I can go into their situation one by one. But not knowing what the various situations are there, I've had to go for a broad outline of the situation and hope that you've got something out of it, and that if you have questions, you will submit them to, and then we will look at them. Like I said earlier on, I have used this part of the discussion deliberately as that part that involves the minimal, the least interference in the act of trying to treat infertility. I have not gone into IVF. I have not gone into injection of sperms into the egg. We will talk about that perhaps in the next session, because these are more complex situations, and the implications of those situations, what are the conditions that it applies to, and how can we get round to finding out who qualifies for those sort of things. And there is the other part as well beyond that, which I always say is dependent on the individual. It's an individual choice. Things what we call gamete donation and so on. Whether egg or sperm and so on. Again, those are issues that are personal. That we will touch on them, how they happen, what the processes are, and all that. We will talk about them. But it is not because they are my view. It is there. It is knowledge that is there. You need to know it. You need to be able to say, I know it, but I don't want it. Or I know it, yes, I can go for it. That's entirely an individual choice. So we will hopefully go through test tube baby, the in vitro fertilization process, and the pattern of stimulation, ovarian stimulation, because it's different. The aim is different when we are doing the test tube baby. Though we are looking for one baby, but we are going to be looking to get many eggs, because we know that not all the eggs will be good eggs, not all of them will fertilize, not all of them will develop into good embryos that can give rise to babies. So, we will need good eggs. We will talk about how we deal with a condition that has been very dear to my heart. Ovarian hyperstimulation. It's a complication that puts the woman at risk in some situation of dying. Some women have died from it. It's a complication of infertility treatment of sort. It's been very close to my heart because I developed an interest and did a lot of research work in it, and more like an authority on that subject today, worldwide. So it's something that is, because I saw it close range, when your patient ends up in ICU, you say to yourself, why? Can it be prevented? And how and what I did to develop a technique that now is used worldwide to prevent that process from happening. So we will talk about the complex aspects of infertility treatment in the coming session. And please, 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 questions. I did say to Pastor Disu, if I don't get questions, then I'm not reaching you. then maybe they don't understand what I'm talking about. Because I can't imagine that everything I said was clear. You know, I can't imagine it, but it's entirely your choice. You know, you have this facility available to you, and I'm prepared to take those questions and drill them down and find, you know, answers to them for you. If you're going through treatment and there are certain things that have been said to you and you think, I need somebody to tell me a little more about that because I didn't have the time to ask those questions, which can happen in a clinic because your time, you know, the doctor wants to get going to the next patient. Yes, you have the option of being able to bring that up in personally. You may not attach your name to it. It will just be read on the forum as a question, and we will deal with it. So, I hope that I have been clear. This is the very beginning of the whole process. I'm not sure that I could show you. I always love those five boys. I have a picture of them here. I'm not sure what exactly.
Oh, there they are.
Okay, can you put them back on? You see them? Yeah, those are this. There's 5 of them. They are all boys. See that middle one was about 0.7 grams, just about half a kilo in weight.
Wow.
You know, when he was born, but they all survived quite nicely. This is not something that we would like to see at this time in present day, and this is a complication of infertility. But people will think, oh well, this is success.
Yeah, I was going to say that.
But personally, at the time that it happened, it was major news in all the newspapers in the Middle East where it happened. And the king of the country was involved at the time because this was something very new and the first time it ever happened in their country. But it was something that I wouldn't want to happen now.
Well, I'm sure there's a couple out there say, I want it to happen so they want it.
Anyway, I hope I've been clear and that we will deal with a lot more in the coming weeks.
Wow. Well, guys, this is happening. This is happening live before us. And we have here perhaps a once-in-a-lifetime opportunity to ask questions. We've been going over this program for the past, this is the 6th or the 5th episode. And at least Dad has spoken for an hour, 15 minutes on each of them. None of us, well, most of us don't have the medical background to have the ability to grasp at first hand what he has been saying. Some of us, we have specific personal questions that we've toiled and we've prayed, we've tried to find an answer to, and we haven't been able to. Don't even know who to ask or where to ask. Now the opportunity is here. I think it will be wrong to walk away from this season, this opportunity, with those questions unanswered when you have the opportunity to ask them. Like Dad said, you don't need to put your name. If you don't want it to be read out, fine, whatever it is, but don't sit on it. A closed mouth, they say, is a closed destiny. Say something, ask a question. Somebody just asked one question here that he said, what are the risks involved in taking big treatment? I mean the IVF. What are the risks involved?
The first and most important risk is failure. Not getting pregnant and not getting what you want because you put so much, your body, I mean, I'm talking about the female now. You put your body on the line, you've had injections, you've had scans, you've been prodded and everything, and you paid such a huge amount of money between you and your husband, you know, and you had hopes. That is the biggest risk and complication that I can see. The other complication that you can see will be what I've been talking about, ovarian hyperstimulation, because when you stimulate the ovary wanting to get 5 to 10 eggs, you can end up getting ovaries enlarged. In fact, I had a picture after this one, I think before these babies, you know, which that's it. That's an ovary that is hyperstimulated. If you let them see this, that's just 2 ovaries that are hyperstimulated. You can see all those dark circles there. That's just a cross section, one cross section of the ovary. And the more you do, you find more and more and more of them. All of these little dark circles that you see are where eggs are located. So this lady, this lady was cancelled. If we went ahead and actually did her treatment, we may end up getting 40, 50 or more eggs. But she will become very ill. Now, that was before I developed the technique that now is used, and most women can have this and then go and rest and have the eggs frozen, and they can come back and have the embryos put back at another day. You know, that's one of the major complications of IVF. Other bits of complication, not very serious infection, you know, bleeding from the operation, you know, bleeding in the ovary, because when you do the transvaginal egg collection, you don't actually see what you are operating on. It's all on the screen, like you can see here now. That's all we see, and we can see the point of our needle, and we go from one follicle into the other and aspirate them. But bleeding can occur, and these are immediate complications. But otherwise, nothing else that I can see. But to my mind, the most important one is failure to achieve what you set out to achieve. Get a pregnancy and have a baby.
All right, Dad, another question.
Yeah.
This one says, when fibroid grows in the stomach, why is it making the stomach so big and with a lot of pain? When women have got hemorrhoids with a lot of pain in the back, is it possible for that woman to get pregnant until 9 months, also with low vitamin D and low iron?
Those are 3 different questions.
Oh, okay.
Okay. Let us deal with fibroids, something which is very common in our environment amongst the black race, I would say. Fibroids begins to give pain when it is protruding into the cavity of the womb, and therefore creating, you know, it's like when the lining of the womb is being shed, especially during the period, the surface is raw, and you have something that feels very much like a little stone rubbing against that area. It gives a lot of pain. If it is within the cavity of the womb or protruding into the cavity of the womb, what we call intrauterine fibroid. We can also have a situation where the fibroid overgrows its blood supply and then starts to die off. And we call that red degeneration, because the blood supply is too little for the size of it. It starts to die off, and the tissues start to die. And as the tissues die, it can be quite painful. It's similar to somebody having a heart attack. A heart attack, when the blood vessel in an area of the heart has been closed, the person feels very severe chest pain and all that, and start to sweat and start to have low blood pressure. It's exactly the same pattern of the same kind of event, although it doesn't cause that sort of life-threatening situation, but it can be debilitating pain when it does happen. The second one is hemorrhoids. Hemorrhoids do not impact on pregnancy whatsoever, except it can be very troublesome for the mother, because when pregnancy occurs, the womb is growing bigger, is putting pressure on the blood vessels down there in the pelvis, in the lower tummy. And that causes congestion. And as that congestion increases, the hemorrhoids will get bigger. And so will create pain. But it doesn't have anything to do with the pregnancy. The pregnancy will continue to survive and grow normally on its own. And the woman can have the baby. But of course, there are symptoms. There's the pain of the hemorrhoids. If it's strangulated, well, that is, it comes out and it doesn't go back in again and it's trapped, then it can be very painful. Of course, surgery can be done. You know, there are different modes of surgery now that don't really need, you know, a knife, you know, like, you know, cryosurgery, we call it, which is freezing it out and all that. Now, vitamin D and what?
Iron.
And iron. Iron is very essential for hemoglobin, and you know, I think we put, I think in Nigeria we put every woman who's pregnant on iron, you know, and folic acid. Yes, it's very important, because your baby is going to take all the iron it needs for producing its blood, its muscles, and all the tissues from you. It doesn't care whether you have enough or you don't have
you don't
enough.
have, you will take.
So, there you need to be actually in a situation where you can support the system, because the baby really doesn't bother whether you have enough iron. It will continue to get what is, you know, it needs to take from your blood, you know, and from your whatever stores you have, it will be depleting it. So you need to be replacing the iron. It's not likely to make you miscarry, but it will make you anemic, because if you don't have enough iron, you don't have enough, create enough hemoglobin for your oxygen carrying capacity. So you get very tired and exhausted. You can't do anything. You know, that's the thing. Vitamin D by itself, yes, we are beginning to understand the role of vitamin D in terms of miscarriages. It's early miscarriages. We're beginning to understand it, but nobody quite knows in detail at the moment. But of course, if you are lacking in vitamin D, your baby needs it for the bones. He's going to get it from you to develop his own bones. So, again, you go.
All right, Dad, another question.
Yeah.
In a situation where there is no pregnancy after treatment for ovarian cyst and low sperm count, what's the next step?
What sort of treatment are you talking about? You know, is it artificial insemination? Is it, you know, is it ovarian stimulation and then try normally? Is it test tube baby, or which is I'll call IVF, or is it a more advanced IVF where you inject a single sperm into the egg? I mean, it depends. The options are so numerous, you know. So it depends on what treatment you took. Like I said, the role of a sperm is to fertilize an egg. If there are very few sperms, I remember in this country in the early 80s, if you're, well, the Royal Free Hospital, where I was head of the department of the IVF department, if your sperm count was less than 5 million, we would tell you, sorry, we can't do anything for you. But today, that's totally a different story. If you have just 10 sperms per high power field, which is something like 100,000 sperms, for example, in the sample, yeah, we can treat it. If you don't even have sperms in the semen and you have it in the, you know, we can find a few in the testicle, we can still treat and have a baby born, a normal baby born. So it depends on what the problems are that the sperms have the capacity to fertilize an egg. That's very important. The quality of the egg is another important aspect, because not all eggs are good eggs, and particularly in relationship to age. Above the age of 40 to 44, things start to drop dramatically, so a lot of eggs start to become abnormal genetically. So it depends on what type of treatment, what age, what kind of procedures were done, but it's a question of what has your doctor advised you to do, to continue trying, or if he says, look, there's nothing else we can do here, we can either be looking at sperm donation or egg donation. Again, that's something that is available in the spectrum of treatment. It's an individual choice to say, look, that is not for me, or yes, I'm sure I can take this.
Next question. Can someone with bulky uterus as a result of
Adenomyosis.
Yes, adenomyosis get pregnant?
Yes. Adenomyosis, the best treatment for adenomyosis is pregnancy. Because during pregnancy, there is no menstruation. The placenta produces a hormone, a large amount of hormone progesterone, that actually changes the lining, and eventually the adenomyosis sort of dies off. It's like endometriosis, which is adenomyosis is a form of endometriosis within the muscle of the womb. Yes, the lady can get pregnant with adenomyosis. I've had ladies get pregnant after adenomyosis. You can excise it as much as possible and reconstruct. And there are medical treatment now that you can use, over a period of 6 months, and it will shrink, it will stop the periods from coming, because the periods, the hormones that induce the period, encourage the adenomyosis to grow. There are medications that can be used to stop the period, on a monthly basis, an injection that can be used over about 6 months period, and the adenomyosis will shrink to the point that then you can immediately, on top of that, start stimulation of the ovary, and then have IVF treatment, and you get pregnant. And the rest of the pregnancy, if you get pregnant, will help you treat the adenomyosis.
Okay, so
Yeah.
The person that was asking that said about after treatment, he said the treatment is with medication, but again, it depends on...
Yeah, it depends. I mean, first of all, did they look at your fallopian tubes? Were they normal? Were they patent? If they were, your scans, have they shown any evidence of fibroids? Or in fact, sometimes an ordinary scan may show an ordinary scan may not show any significant fibroid. But if you remember, I talked about a procedure called hycosis.
Yeah.
I think it was in the last session or the one before.
The one before.
Which is a better form of investigation than the HSG, which is X-ray. Yes, can give you a clearer idea of the cavity of the womb. Sometimes there are little polyps, which are fleshy growths within the cavity of the womb that may be preventing an embryo from implanting. So it's adequate investigation is essential, and if they've treated you with medication, then the next stage should be, look, should we not be going for the test tube baby treatment, and see whether actually, the eggs get fertilized, they are good quality eggs or not, and all that. Yeah.
Yeah, I think for now that's all the questions. Wait, let me check my email, just in case. No, nothing in the email on the program. Well, that's all the questions I have here. And we are.
I know it's a bit of when you talk. I understand what I'm saying, but because it's my area of specialization, it's what I did for a living for years and years and years, and I have a passion for infertility treatment, reproductive medicine. I've done a lot of research work in that area, and I'm still interested in doing a lot of stuff. So it would be easy for me to talk to you, say all these things, but sometimes I wonder if I were sitting on the other side, would I understand all of this stuff? But if you do at any time think that, yes, I do not, then let Pastor Disu know, and we will try and deal with them.
Dad, it has been another wonderful. I have sat here, tried to keep my mouth shut because I am learning. Just like we all are. I am learning too. These are things that I've never heard before. Thank God I didn't have to need any treatment or whatever. But even with that, I have friends who are still trying to have a baby. I have families who are still trying to have a child and all of. So for me, this is giving me, it's putting me in a situation where I'm not just understanding it for myself, but I'm understanding their position and what they're going through. And maybe with this that I'm learning now, I can put a hand on their shoulder to say, look, what about this? How about that? Do you know about this? Do you think you've tried that? What have you done in this area? And so these are tools that Dad is putting in our hands. Maybe not for us, but it could be for others.
Yeah.
Our friends, family, colleagues, people in church, people at work, your neighbor, anybody. And you don't even know where you will be tomorrow. You might not need it. But you have children.
Of course.
And children's children, your cousins, your nephews, your nieces, and all of that. So what we are learning here is just if we had gone to Cambridge University, I don't think we could have learned any bigger or better than this.
We learn.
No, well, we will learn, but not. I don't think in so detailed like this. Dad, once again, thank you, sir. Thank you so much.
Thank you, everybody, for being patient with me. And sometimes I rush through some areas, maybe, but I hope you've understood as much as possible of what I was trying to communicate. And if you have questions, the forum is still very open for that. Send them in. We can deal with them next week.
Yeah.
Hopefully, I won't have one of those events of the teacher wanting to be taught again and running away. So thanks a lot for being patient and being with us.
Thank you very much, everyone. It's been a great time together again this week. Now, this is all I ask. You have been fed, and I have been fed. Let's go and tell somebody about it. Let's share this program on our timeline so that others who are not who are not on this program right now, can partake of the blessing that we've all enjoyed. Because to me, this is a food worth sharing. So let's go and share it. But more than that, like Dad said, this is the first part of the treatment topic, of the treatment program. Thursday next week, the same time on this platform, Thursday, 8 p.m. Mark your calendar. Talk to your friends about it. You know somebody who needs to hear this. I know somebody. We can help somebody. Also, our next Become a Better Man program is coming up in August. Hopefully by next week we will confirm the date and the venue. And this time it's going to involve a day out. We'll be going golfing. You're going to go and play golf. Now, before you start saying, oh, that's not for me. No, no, no. None of us is Tiger Woods. None of us is McElroy. We are all going there just to have fun. We will get the clubs there. We will get the whatever we need. We will get there. Just bring yourself. Yeah. Like I said, next week we will announce.
I hope the women are also going.
Oh yes, especially for the ladies, because it's easy to say, oh, this is a man thing. No, it is for everybody. I've spoken to the golf club, the golf center, and they've said, yes, everybody is welcome. So please, ladies, especially ladies, bring your men and bring yourself. So until next week, when we meet again on this platform, this is Tunde Disu and Dr. Daniel Imoideme saying once again, we are on a journey of discovery. We are going somewhere great, and we will not stop. We will not cave in. We will not give up. We will not be discouraged until we reach the destination called better man and better woman. So until next week, good night. God bless you. Bye-bye.
Bye. Yeah.